Good morning. So welcome and thank you. Is it on? Hello? Okay, good morning. Welcome and thank you for getting out of your warm beds this morning to attend the conference. I know as a student it's been something that I've really enjoyed being on the other side of. The camaraderie and kind of the connections across the cohorts and across the MEP have been something that I really cherish, and so I'm glad that you've chosen to be here. And so thank you. So I want to talk a little bit about, I was placed with Jay in January of this year, and I want to talk a little bit about the research that I did while I was placed with her, but also kind of the broader context of, as you listen to my presentation, maybe think about how you want to navigate ideas around informed choice and infant feeding. As midwives, as protectors of normal, as guardians of natural childbirth and protectors of breastfeeding, I think it's also something that if we are truly providing people with informed choice and informed decision making, that we ourselves really think about what our biases are around infant feeding and how we might navigate those relationships with people. So Laura kind of indicated where this research came from and where the idea of my work with Jay came from. And so part of it was that there are two hospitals, and St. Mike's will now be the third that I'm aware of, in Canada that actually have postpartum orders that are present on the floor when clients who are HIV positive give birth. And so it's part of the orders, any kind of postpartum period, here's the medications that the person is to be administered, and here are the things that we're going to do and how often we're going to check vitals and all of this sort of thing. And so part of Jay's idea was that she wanted to actually develop a formalized order for lactation suppression in working with the clients that are HIV positive. So in the global north, where we have, for the most part, water that is available to us readily, and clean drinking water, and formula is readily accessible to people, the recommendation is to not breastfeed if you are HIV positive and have given birth. In other parts of the world, that recommendation is different. So I'm speaking from a global north context where the recommendation is to not infant feed. And that's from a standpoint of like the medical recommendation is to not infant feed. And so what my presentation speaks to a little bit is also the social and cultural kind of context of infant feeding around all of us, but also clients in particular that are HIV positive. So navigating this period and lactation is difficult in many instances, but specifically to the context of HIV positive clients, because of this idea of social constructs of breastfeeding and societal and cultural implications of what it means to infant feed and breastfeed. In some instances, the actual how you choose to feed your infant can be seen as a subtle, nuanced disclosure of whether or not you are in fact HIV positive, which can be really devastating for some people. And so there's a lot of expectations around how one is supposed to navigate feeding their child. In addition, there are a lot of personal kind of guilt and loss around that. We often will talk about infant feeding and situations of loss like stillbirth or miscarriage. But there's more research that's up and coming that has been infant feeding and guilt and loss around people who are HIV positive and because of their medical situation are unable or choose not to feed their infant. And so that's something else that we think about. And then clinically, and as clinicians, the other thing that we have to navigate in this infant feeding relationship is the pain and blocked ducts and the symptom picture that happens when milk does come in and there isn't an infant on the end, like on the receiving end of it. And so that's something that where this protocol came from was layered with actual clinical management, social and kind of cultural context of navigating someone's HIV, infant feeding, familial relationships, and so that's sort of the basis of where this is born of. So questions, why aren't you breastfeeding? And so it's really important ahead of time. So part of the care of the clients in P3 becomes navigating what will be your story as to why you're choosing not to feed your infant. And so oftentimes having a story there is in place ahead of time. Oh, I'm on some high levels of iron that I'm not supposed to feed the baby. I'm taking a medication for whatever, some story is created, and so that is something that people can then tell their families and tell their friends and people in their sort of social and cultural circles, and that can help them to kind of just shut the walls off around why they're not breastfeeding their baby. So it's interesting in that not only are you navigating that kind of communication, but it's laden with different feelings around that, and on top of that, the person's milk does come in, and that's laden with certain feelings and pain and discomfort and all of the grief and other stuff that comes up as a result of it. So to have a protocol in place on the floor, sorry, I've skipped ahead too quickly, to have a protocol in place on the floor that can prevent the milk from coming in the first place, all of that, my milk just didn't come in. I can't feed my baby, I can't breastfeed my baby because my milk didn't come in. And it just, the way that that impacts people's care and people's emotional journey to parenthood and to recovery after the birth is really powerful and really profound. So in trying to create this protocol, I not only needed to appreciate people's sort of lived experience and where they were coming from in navigating this infant feeding journey, but also what is the physiology of lactation and what is the physiology of this drug and the appropriate indications and contraindications, because if you're going to establish it as a protocol on the floor, you need to know really intricately how it works and how it doesn't and when it's appropriate to use and when it isn't. And so this is just a little bit of just so you understand kind of the underlying how the drug is impactful, is prolactin levels. So the blue line is prolactin, the red line is the prolactin levels and the blue line is the progesterone levels through pregnancy. And so toward the end of the pregnancy, the prolactin levels are highest with the actual, there's a spike and a peak that happens at the birth as the placenta is released. Excuse me, as the placenta is released, there's this spike in prolactin, and then estrogen drops off. And so that spike in prolactin is a slow kind of gradual, as you can see, curve that kind of descends. And so L1 is the changes in the breast tissue that happen through pregnancy, lactogenesis 1. Lactogenesis 2 is where the Cabergoline, which is the drug that I'm talking about, where it has an impact. There's that physiology and the hormones at birth that actually create proliferation and create the milk coming in that sort of 2, 3, 4, 5 days postpartum. And sort of we've got 30 to 40 hours after birth that now we start, as the baby's nursing, lactogenesis 3 is the supply and the demand of breastfeeding. And so where Cabergoline has its impact, I'm going to step away from this mic for a moment so I can show you here. It's given in the immediate postpartum, so within about 12 hours of the birth. And so what it does is it, instead of making this curve kind of have a gradual decrease in the prolactin levels, it's like it splices out this middle part, and all of a sudden we go from high levels of prolactin to low levels of prolactin. Because of the action of the drug on the pituitary and the hypothalamus, it actually just drops off the prolactin levels. And so because the prolactin levels are dropped off, we actually don't have the milk come in the first place, for the most part. There are some very small few instances where milk does come in, but the symptom picture is much less severe as far as engorgement is concerned and the associated discomforts with it if someone has been administered the Cabergoline. So, and this is all in my slides, so I'm not going to get into too much pharmacology.
Do you want questions now or
Maybe if I can just talk, and then if you've got a question, please feel free to write it down. I'm happy to navigate that. It's just in the interest of, I think, smoothness and flow. I'll just keep talking if that's okay with everyone. So again, I've made the slides available to the AOM. If anybody's interested in the pharmacology of things, I'm happy to email you more information about the drug. But basically, it's a D2 dopamine 2 receptor agonist. It's an ergot derivative. So for those of you in pharmacology, if you think of ergonovine maleate or ergot as a postpartum hemorrhagic drug, it has a very similar actual chemical derivative. And so thinking in your pharmacology brains, it also has an implication to blood pressure in the same way. So we'll come to that when we talk about contraindications. It's administered orally. It's also a drug in much more significant doses, probably 6 times the doses, and on a weekly and daily and regular regimen. It's used in Parkinson's. So from a standpoint of dopamine agonist, it actually is helpful in Parkinson patients when they're navigating tremors and some of those associated clinical manifestations. And so that's where it was originally used from. So this is not an off-label use, the way that for domperidone, the increasing lactation is an off-label use. This is an actual on-label use. It's just this is the appropriate dose, is either 2.5 milligram tablets or 1 milligram total orally in the immediate postpartum. And what it does is it helps to stop that prolactin release that happens as the placenta separates. And here's a little bit more again around, around the drug itself. What I would want to draw your attention to is the contraindications and the cautions, because that's something that clinically we need to be aware of. Uncontrolled hypertension, preeclampsia, if people have different disorders of the lungs and the heart, so different fibrotic conditions, there are some conditions where there are valvular fibroses in the heart where that person is not indicated to be taking this particular medication. Different gastrointestinal bleedings, and the last is history of psychosis. And again, some antipsychotic drugs have an action on that D2 receptor, and that's where it comes from, is that now you have 2 drugs that are sort of fighting for the same receptor, and because of that, we're not exactly certain as to how safe it is in the context of people that are suffering from different psychoses, and so it's to be used with caution in those situations, or not at all. And so some of the side effects, mostly people are dizzy and nauseous, but if they're eating a little bit in the postpartum period, then that can help with the dizziness and nausea. And so I want to tell you a little bit about how I actually went and worked on developing the protocol. And so part of it was that I was asked to not only, here's this drug and go and research the drug, but what my preceptor really wanted me to capture and to understand to the best that I, as a person who is not living with HIV, am able to, is the context of people's lived experiences around infant feeding, around the stigma of living with HIV. And so that was where things started, more from a social and attempting to understand a cultural context for people's experiences. And then I went and surveyed some of the current existing protocols, researched as much as I could about the drug and if its efficacy and its contraindications and any problems that we would have around using it. And so as I get ready to wrap up, I want to talk a little bit about how the protocol, why this protocol is really important, and then how you as aspiring midwives might think about this drug in the context of providing care to people. So there are totally experiences where avoidance of breastfeeding is clinically necessary and where suppression of lactation is the desirable outcome. So we have to think about that. And it's not about our judgment of whether or not we think someone should not breastfeed or allow their milk to come in or not, but as clinicians, it's about providing people with informed choice around infant feeding. So the patient suppressing lactation in the early postpartum period is at risk of pain and engorgement, in addition to potential stress or grief over the decision to not breastfeed or the inability to breastfeed. or the medical appropriateness of them to breastfeed. So appropriate management diminishes the milk supply with as little discomfort physically and emotionally as possible, and therefore minimizing any appropriate potential complications. And so the big picture here is where might we use this particular protocol? And so for sure in the instance of HIV positive clients, it is something that is part of the standing orders. To my knowledge, there are in the order of 20 people since the beginning of this protocol becoming in place early this year that have benefited from the administration of the drug. And the feedback through word of mouth from my preceptor to the clients, to my preceptor, to myself, is that they're immensely grateful to have this as an option. It's people who have had previous children and some who haven't had previous children, but people that appreciate what it is for the milk to come in and all of the feelings and physical discomforts that are associated with that. So there is really a sentiment of gratitude on behalf of the clients. And so that's something to think about. If there's a situation where there's a neonatal loss or a stillbirth, that would be something that would be appropriate. And other things, adoption, custody loss, and when patients are taking medications that are not appropriate for infant feeding. Okay, I think that's all I have to say. Yeah. So there was one instance where it wasn't used, and it was the risks-benefit analysis was such that the person had actually had a couple psychotic episodes in pregnancy, and it was chosen not to administer it for that particular reason. But as far as midwifery clients and clients that are appropriate for midwifery care, there, the people that have these different fibrotic lung and heart conditions are screened out of our care, typically speaking. And so it would be something I just encourage you to think about. And it's not part of the midwifery pharmacopoeia, so that's something also to note. But there's some interesting discussion around that. So I thank you for your attention, and that's it. Sure.
I don't have all of my science in front of me as a question. I'm thinking of colostrum. So at this moment in time, I think society tells us that colostrum is like really good for an infant to have. Would it still be possible to have that drug given postpartum, but still breastfeed so that the child can get colostrum?
So the idea around not wanting, in the global north recommendation, HIV positive clients to infant feed, to breastfeed, is around vertical transmission,
yeah,
right?
I think of the other scenarios, like the adoption
Oh,
or whatever.
but you can't have the chicken and the egg, right? Like you either choose to suppress lactation. And so, yes, there is colostrum in the immediate postpartum. If you're giving the drug within 12 hours of the birth, then maybe the baby has 12 hours of colostrum. Because it will still take time for what is in the breast to actually dry up and the actual physiology of the breast to change. Yeah, so in that particular situation, so sometimes I've been in situations where if it's a custody situation, the birth parent has actually been allowed to be with their child for a stay of 4 or 5 days. And so maybe that situation would be where you actually don't want to suppress lactation because, right? So it's a bigger part of bigger clinical management, but certainly not, with HIV, it has to do with vertical transmission and the viral load in breast milk and uncertainty around, transmission rates, especially based on a particular individual's viral load. And so it's kind of the default setting is to not infant feed, breastfeed, excuse me. It's encouraged to infant feed.
Yeah. Pauline, I'm just curious in your research around the different clinical situations where this drug would be appropriate, if exploration of sexual trauma or PTSD were any maybe someone not wanting to breastfeed because it could be triggering through sexual trauma or any other kind of trauma, if that came up in your research?
So that's a great question. So, can I give you the mic? Do you mind?
My question was, in Pauline's research around clinical situations in which this drug would be appropriate, if it had come up, if a client had experienced sexual trauma or another kind of trauma and would prefer not to breastfeed to avoid re-traumatization.
So, you know, and it's interesting, in hindsight, I look at the way that my preceptor encouraged me to navigate this, and it had nothing to do with starting with the drug and attempting to start with the lived experience of people so that I could appreciate, based on what I was reading and hearing, something that was not knowledge to me. I don't know if any of you have attempted to navigate ideas of grief and loss in infant feeding in situations of apprehension, HIV, people that are being discharged to living on the streets, people living on the margins. People are invisible. When you talk about lactation suppression, or you talk about grief and loss in infant feeding, it's all about stillbirth and neonatal loss. And it's not to say that that lived experience isn't important. It absolutely is. But how things are polarized in literature, like my Google search had to be grief and loss and child apprehension, and like it was probably 20 terms before I found 4 articles that spoke to the grief and loss and emotional experience and ideas around trauma. And so absolutely, it isn't a specific layer of what I was researching, but if you think about people, we're not silos of who we are, right? Oftentimes sexual trauma and drug use and homelessness, and there are pillars of what makes us up. And so those things are not isolated of one another. And so it wasn't teased out just from a standpoint of sexual trauma and avoiding breastfeeding, but absolutely as midwives on our radar, and should absolutely be part of our, how do I help this person make choices around their infant feeding decisions, and how do we navigate this journey, and how do I inform them? How do I inform them so that they're the one making the decision? So I think that's a brilliant question, and sadly it wasn't a specific layer of what I was able to tease out. Okay, great. If anybody else has, oh, I'm sorry, did you? Sure, can I give this to you so that people can hear? Oh, great. Thank you.
Is Cabergoline, is it relatively new in its development, or how long has it been used for?
Like the first research that I was able to find is in the order of like the 80s, 1980s, that it was, there's a bromocriptine is the previously used drug, but had quite a few side effects. And that was something like through 60s, 70s, 80s, that there were kind of a push and pull as to which was the drug of choice. And so as it stands now, when we talk about lactation suppression, say for instance in the stillbirth situation of a client who's undergone a stillbirth, it tends to be the drug of choice because it has much less side effects than the bromocriptine has in the past. Yeah, so it's been around for a while. Yeah, you're welcome. And you said there were 2 questions?
I guess it's more general. And do I have to administer the Cabergoline?
No. So this is on orders of a physician. So this is where it comes a little bit tricky. And so I have heard, like, our pharmacopoeia is kind of evolving, right? And so now it's like you can prescribe this drug and this drug and this drug and this drug. And what they're looking at doing is actually allowing classes of drugs. And so at this point in time, there's not, I don't think, discussion around a lactation suppressant class of drug. But there are some jurisdictions in Canada that are navigating a discussion around allowing this into the midwifery scope of practice.
Thank you.
Was that as neutral as I could possibly be without saying anything that was...
So, Pauline, if we're not at St. Mike's or at a hospital that has a standing order or a protocol for this drug, and as midwives or midwifery students, we have a client who we think would benefit from this, if we went to an obstetrician, would they be like, I have no idea what you're talking about, this is too new? Or would they say, yeah, I can do this for you?
So the drug is not new. I think the idea of, you know, that I'm not sure of, because I haven't, there was one situation where I had a colleague contact me. Her baby died at, her client's baby died at, I think 7 or 8 days postpartum. And so she was like, tell me about the drug, tell me. And it's not, like, it doesn't help to dry up milk where lactation has already been established. So it's really quite interesting to navigate, like it has to be in that immediate postpartum. So, I don't know. I don't know, but it's not like, I think if people have a relationship with the obstetricians at their hospital, the way that midwives hopefully do to some extent, that at least an intellectual discussion around it can be had. And if you type in Cabergoline and lactation suppressant, like there's tons of stuff that comes up. So to say, look, I've this drug and I've heard about it and here's the research on it, what are your thoughts? And it's something that like most hospital pharmacies have on stock because it's a anti-tremor Parkinson medication, right? So it's already in the pharmacy. It's not like they have to kind of like compound it or create it or whatever. So I think it's certainly a space to have some really interesting and really amazing interprofessional kind of navigation. Yeah. Okay, thanks.